Welcome to Variations 4, the neurological unit. We'll be covering question 8 to 10 in this video. That is intracranial pressure, rather increased intracranial pressure, a little more on symptoms, and a bit on collaborative care. We're going to address question 8, explain the vital signs changes that come with later stage intracranial pressure increases. And we're going to talk about question 9, pupil and motor dysfunction that accompany increased ICP. We're going to talk about all that at once here by way of looking at your PowerPoint. Of course, I do encourage you to come back after and read through the explanations given in 8 and 9. Well, in 8 at least, it will summarize some of what I've said or I'm about to say. So yeah, if we look here at your PowerPoint, first of all, we're going to focus really on motor changes, vital signs changes, and pupil changes. You have to imagine early signs. Well, what are we saying there? That maybe there's swelling or bleeding on the brain, but it's, just starting out here. Symptoms are just starting to show. It hasn't reached its most severe point yet. And so you get all these changes up here, which I'm not going to read through. Those should be pretty intuitive when you think about decreased perfusion, decreased cerebral perfusion pressure, which ultimately, if we don't help the patient out, increases in ICP, as we noted in our equation, end up lowering perfusion pressure to the brain. And we already know these things occur. We've seen it in our own practice already. If the swelling is bad enough, it will compress nerves, the cranial nerves. And the reality is, if the swelling's on the left side, because the cranial nerves for the pupils don't cross over, you'll have a sluggish pupil response on the same side as injury. For example, it's just different from the body. With stroke, it's the game of opposites. If you have left-sided stroke, then the right side of your body is typically the one that's weak. So when you move up to cranial nerves, the nerves that control the cranial regions, pupil size being one of them, it's one of our key indicators here. If I've got bleeding on the left side of the brain, I can expect a dilated pupil on the same side. So bleeding on the right side will cause a sluggish, dilated pupil on that same side, the right side. It might be dilated, it might not react quickly to light, or both. As things get worse, you start to move to, as the bleeding moves to the other side of the brain, because it's just getting worse and not controlled, you can eventually have bilateral dilated pupils that are fixed. So again, when it begins, the pupil that's affected, the pupil that is sluggish in response to light and potentially dilated in size, larger in size, is on the same side as the swelling or bleeding on the brain. As things get worse and the bleeding moves to both sides or swelling to both sides, both pupils become dilated, and when it gets really bad, they become fixed and there's no response to light at all. You shine a light in their eye and it stays dilated. In terms of vital signs, we can see a variety of things as we move through, but what I want to point out to you happens in the mid to late stages, and it's as we move along to later stages and terminal signs, what's happened here, the bleeding's gotten worse, the swelling's gotten worse, the ICP has gone up, and CPP is going down. Okay, so these are late stages. Hopefully you never see these types of vital signs, something called Cushing's triad. And this is in your notes. It's also in your maps. You can look that up. It's in your textbook. It's called Cushing's triad. And it's a combination of 3 things: hypertension, especially a high systolic pressure, lowered heart rate, and ineffective breathing pattern. Those 3 things: hypertension, lowered heart rate, and ineffective breathing pattern. Those 3 things together are called Cheyne-Stokes. And if you No, sorry. Those three things together are called Cushing's triad. And if you take them all together and they happen within the context of a head injury, your patient is not in a good way. They're going downhill really fast. This is a problem. Hopefully you don't see that on the ward. There's various theories put forward as to why those vital signs come up, and you can read up on those on your own. I've included some of them in our notes, but that's what you have to look for. That's Cushing's triad. But in addition, you can have other vital sign changes that are not Cushing's triad. For example, the hypothalamus, when it's compressed, can cause changes in temperature, high or low. Okay, so finally, let's look at motor response. And to do that, let's look at our PowerPoint here, a different slide here. I really just want to focus on A and B. You've got titles up here, good. So A is decorticate. First of all, let me say off the top, A and B are postures that are both signs of late stage increased ICP. Both of these are not good, okay? These are not good. Both of them are pretty grim if you see a patient in this condition. That being said, B is a later stage than A. So in other words, question for you, which one of these is worse? B is worse. B means it's later stage. Okay, now you may see them posture like this in their natural resting state. I have seen that, and it's kind of an ongoing thing. Saw a patient with a gunshot wound injury to the head, and it was something like this. But also, it might not. Maybe when they're laying without any stimulus, the arms are at their side, the legs are relaxed, and when you apply pressure to the trapezius in the form of a neuro check, when you apply pressure and you try to stimulate them, they go into this posturing. And that's a very common thing to see too with late stage ICP. Either way, whether it's just with contact or whether it's perpetual, these are two postures. The first one is known as decorticate. The second one is known as decerebrate. Those are the two you want to know. The second one being much worse. This is called abnormal flexion. This is another name for it, abnormal flexion. And this is called abnormal extension. These are just other names for it, which you might see a little later on in the unit. Okay, finally we move to question 10. Question 10 is asking us to review care for the patient with increased ICP. We'll look at 3 of your maps here, these ones here, to kind of cover that. So starting with 4.1. Mannitol, why would we give that? Mannitol is a hypertonic solution. Okay, so it's hypertonic. And let's look at your picture here to kind of go through that one. So if we head back to this diagram here, imagine there is edema here. There's swelling, there's fluid all over the place. They might give mannitol a hyperosmotic solution with lots of oncotic pull, running it through the vessels, as its oncotic pull will draw fluids from the tissues into the blood vessels. That could be one approach, thereby decreasing the cerebral edema. It's possible they may want to give corticosteroids. Can you answer why? Well, if inflammation is causing the edema, and we did talk about that earlier, then decreasing the inflammatory response might help to decrease the edema. And decreasing the edema helps to decrease ICP. Next, on to page 4.2. These basically, barbiturates are for sedation. We want to have the least amount of stimulation to the brain. This decreased metabolic rate decreases blood flow, thereby decreasing ICP. Don't worry about hyperventilation therapy. We're not going to get into that. Finally, we look at map number 5, and just kind of with everything we've said, we'll just take a second to look through it, and I'll point at anything that that's not totally obvious or that we haven't talked about. A burr hole is when they have a hole, they drill a hole into the cranium, and they actually will use a drain to remove blood from the cranium. So we've talked about a lot of these. An EEG is an electroencephalogram. So they're looking at the brain waves. GCS is Glasgow Coma Scale. We will talk about that in a bit. Okay, that should make sense. You'll want to get blood gases because, for example, if you find out that the O2 is low in the blood, then that could be causing cerebral edema too. That could be causing increased blood flow to the brain too. So, this all kind of ties into what we've said so far. They probably can't eat. They might need some TPN. You don't want them getting constipated. You don't want that kind of straining. So if they are at risk for nausea and vomiting, you might want an NG tube to avoid vomiting because vomiting increases intracranial pressure. That's our usual lung sounds for immobile patients. The basic stuff from level 2 with turning the patient, basic care, all that kind of stuff, avoiding pressure ulcers, avoiding contractures, that should kind of be review. Any kind of Valsalva maneuver can increase blood pressure, any kind of straining, any kind of coughing. All right, you don't want to give all your care at once and overwhelm the patient. Ideally, each care visit is short in time, but that's the ideal.